Good evening to everyone. I'm Dr. Onkar Swami. Welcome you all in this month's HIV update. And interestingly, we have a very interesting update from CROI 2013. And this event is brought to you by makers of Spegra, Viropil, Tunact, and Inbec. So we know that 15 days back, there was a 30th CROI 2023 in US. And to take and bring the discussion to Indian audience, we have eminent faculty and a speaker, Dr. N. Kumarasamy, sir. Sir is a chief and director of VHS Infectious Disease Medical Center, Chennai, India. He is a director at Chennai Antiviral Research and Treatment, CART clinical research site of US National Institute of Health, which conducts therapeutic and biomedical prevention clinical trials in infectious disease. Sir is also clinical investigator for research projects with Brown University, USA, University of California, San Diego, prestigious Harvard University, and New South Wales University in Australia. Sir has been a clinician and researcher in infectious disease for more than 25 years, and he has published 450 manuscripts in peer-reviewed medical journal. So sir is an advisor and an expert panel member for WHO ARV Treatment Guidelines Committee and a clinical advisor to Clinton Health Access Initiative. It's our privilege that, sir, you are bringing some of the important aspects from last conference. And we feel that this important aspect is very important to the Indian practitioners who are practicing here but could not attend this conference. So your expert commentary is going to be a great feast on a Saturday evening. With this, my small introduction, I would like to hand over this session to our faculty, Dr. N. Kumarasamy, sir, and I will take a beg a pardon over here. Thank you very much, sir. Over to you, sir.
Right. Good evening, everyone, and thank you for inviting me, to speak to you all today. I'm going to quickly share my slides, and Dr. Onkar can tell me you're able to see my slides.
Yes, sir.
In full screen.
Yes, sir.
Right, and it's moving, right?
Yes, sir.
Okay, great. So I'm going to speak to you for the next 30 to 35 minutes on some of the key updates on antiretrovirals from the recent concluded CROI 2023. As many of you know that this retrovirus conference happens every year in the US. So this is the 30th year. The last couple of years due to COVID, these are all purely virtual. So after 3 years, it was the first time in person this conference happened. So this was been organized between February 19 to 22nd in the city of Seattle, where you can see this is a Space Needle, which is being one of those key landmarks for the Seattle city. And this is a famous public market center where this is a birthplace of Starbucks. If you know about a coffee, Starbucks, the first store started somewhere here. And now we have stores, even my own neighborhood of Chennai. So this is all about Seattle. So the conference happened between Feb 19 and 22. It's such a huge conference. It's a very high intense conference with science and high-flown therapeutic interventions, and as well as prevention interventions. Discussions happened, and a lot of key antiretroviral therapeutic related discussions happened, and some of those newer drug discussions all happened. There are several presentations. The conference is so huge. I think the next 35 minutes, I'll not be able to summarize the full conference, but something what will be relevant for you two clinicians. So as an outline, I'll talk to you about long-acting antiretrovirals. There will be a lot of discussions and interesting presentations. There are also, along with antiretroviral drugs, there are broadly neutralizing antibodies. It was been initially tested, had some setbacks. Now we had some combination BNAbs, which has been promising, which I'll walk you through. Also about one of those newer molecule called Islatravir, which I had discussed with this group in the past. Then because of some reasons on lymphocyte apoptosis, this drug was been put on a pause. Now it has been coming back. I will walk you through that. as well as from our own study called DEP study for second line, where it was been presented as a late breaker. It might be very useful to you in your clinical practice, which has been done in research limited setting, including Chennai. And also our own theory of weight gain and integrase inhibitor. I'll walk through some of those presentations and how we can sort this out. And of course, I'll also discuss a little about monkeypox in HIV. And of course, monkeypox itself can be a webinar, but it's in HIV. There are some presentations, how it will be useful to you. To start with long-acting injectable, as we all know, so we have this drug called Cabenuva, which is a two drug. One is cabotegravir, which is an integrase inhibitor. Another one is rilpivirine, which is an NNRTA, which has already been approved for use for treatment by US FDA based on several pivotal trials. A study on LATE-2 earlier shown in people who already have suppressed viral load. If you stop the oral therapy and give these every 2 months injections of cabotegravir and rilpivirine, it maintains a suppression, which was also well supported by two studies, Atlas and FLAIR, in the past. So following this, US FDA recommended for treatment and became part of the US DHHS guideline, as well as some of the developed world treatment guidelines. So also this drug, cabotegravir alone, it's also been now approved for prevention as a long-acting pre-exposure prophylactic drug. So in this conference, again, to support this data, earlier published data, there was a presentation from a group called SOLAR. So what they did, again, is a switch study. Patients who are on a combination of tenofovir alafenamide with emtricitabine and bictegravir, another integrase inhibitor, who have been suppressed viral load, and they have been switched, one group of patients to long-acting cabotegravir and rilpivirine, another one continued the same everyday oral therapy. So again, this study, not only just to understand the maintenance of virological suppression, but also the acceptability of this long-acting injectable by our patient population. So this SOLAR study compared long-acting cabotegravir with rilpivirine every 2 months versus daily oral bictegravir, emtricitabine, and tenofovir alafenamide, both virological outcomes, safety, tolerability, and the patient's treatment satisfaction. It's a very nice randomized study. You can see this schema of this randomization. Patients who have been suppressed with oral therapy with the triple drug of TAF, emtricitabine, and bictegravir, they were randomized into 3 different groups. One group continued the same oral tablets every day. Second group, they're randomized to receive oral cabotegravir and rilpivirine every day to achieve a drug concentration for at least for a month. Then they were moved to every 2 months of long-acting cabotegravir and rilpivirine injectable. The third group, even at the baseline, after suppression with the oral triple therapy, they have been randomized to long-acting cabotegravir and rilpivirine. The study went up to 12 months. Then after 12 months, all the 3 groups been followed up in an extension phase with the long-acting injectable and rilpivirine. The primary endpoint of this trial is been the proportion of the patients with HIV RNA more than 50 copies by FDA snapshot analysis and with a modified intent to treat analysis. And also the study assessed as I said, about the patient satisfaction. It's a baseline characteristics. I will not go into the details. It's been similar in both the groups in terms of age and race and BMI. So there is no question of any confounders. We look into the primary outcome. This bar is being shown as in terms of virological suppression of less than 50 copies. The orange one is a long-acting injectable cabotegravir rilpivirine, and the blue one is bictegravir, emtricitabine, and TAF as a everyday oral tablet. If you see, there is no difference in terms of virological suppression. It's not been both are not being statistically significant. It's been both are equally being suppressive, and it very clearly shows that even in the SOLAR study supports the earlier data on this long-acting cabotegravir or rilpivirine. Someone who's been already been suppressed viral load, it maintains a suppression. Again, the snapshot analysis very clearly shows that there is no difference in terms of patient outcome, and also patients who had a increase in the virus level again, when they switch to those baseline therapy, again, it get, suppressed. So there is no question of patients being developing, any other resistance mutations in that. Coming to the safety events, the long-acting cabotegravir has been safe, and except the injection site reactions, which has been coded as one of those adverse events, other than there is no major safety concerns to withdraw, these particular molecule from these study participants. So this particular slide is a very important one, especially for our patient population here. So what they look into that is they also administered a satisfaction questionnaire, which has already been well validated by different forums, including by WHO. So what they found in that is participants who received long-acting injectable, there are 90% of them preferred long-acting injectable versus 5% with oral tablet. This very clearly shows that our patient on a long run don't want to take these tablets every day. So this is something what we learned from this study, which I think will be a very important carry-home message. If we don't assist our patient population with that, they may not take the everyday oral tablet, end up in resistance, and come to you for second or third line, regimen. This is something what been found from this particular SOLAR study. The SOLAR study concluded stating that this long-acting cabotegravir rilpivirine administered was being non-inferior as compared to TAF, emtricitabine, and bictegravir. The confirmed virological rate was very low in the cabotegravir rilpivirine arm, and they all got suppressed on a different ART regimen. They did not develop any, resistance. It was well tolerated, except these injection site reactions, which all resolved very mild. But very importantly, the treatment satisfaction improved significantly among those patients who received these long-acting injectable. I think that's something an important carry-home message of 90% of the participants were preferred long-acting versus 5% versus everyday, oral tablet. Now, again, this particular study was conducted on a well-suppressed population who got a suppressed viral load, where they randomized to give this long-acting injectable. Will this work in a patient population where you do not know the viral load? Hey, patients come to your clinic, you do not know their viral load, can we directly give this? I think to support that hypothesis, there is another very nice study was been presented by Monica Gandhi from San Francisco. So this is on long-acting cabotegravir rilpivirine in a chronic population. As we all know that all the earlier studies, FLAIR, ATLAS, now the SOLAR, all supported on patients who are already on virological suppression. So this particular study, which I'm going to show you now, evaluated the efficacy of long-acting cabotegravir and rilpivirine in an urban HIV clinic population, where in this clinic serves primarily HIV patients who are all in a public setting with a lot of issues with adherence, and they have housing instability, patients with substance use, and various other mental illness, where we all know that this type of patient population have a poor adherence. So this study was carried out in San Francisco at Ward 86 HIV clinic, which is a very famous HIV clinic in the United States, one of the first HIV clinic which was initiated way back in 1980. So where there are no requirement when they did this study, whether the patients are suppressed or not, or prior use of any oral ART or not. It just recruited the patient who came to the clinic, whether they have high viral load or suppressed, into this study. If they are willing to come to the clinic every 4 weeks to provide contact information and also participate in the study. But one thing they did was they did a resistant testing, and if someone was got an RTA mutation, particularly to rilpivirine, and as well as to integrase, they excluded. So this is something very important criteria, for that particular study. And a study looked into the virological suppression, which was stratified by HIV RNA of more than 30 copies at the initiation of long-acting cabotegravir and rilpivirine. So this is a baseline characteristics. They studied on 133 patients who came to been followed in their clinic, and there's a median age of 45, and you can see the gender, race, and housing, and the various other baseline characteristics. And also, when they looked into those patients who are being virologically suppressed versus who are being non-suppressed, as well as patients who had any mental illness, almost like 51% of them had mental illness. Very clearly shows the population who deserve this type of long-acting injectable. When they looked into this study, very interestingly, they found in that if you see these graph, 97% of them, they're expected to achieve the virological suppression by 26 weeks. So this is something what even the investigators initially didn't think about that. Hey, they brought up patients, they didn't know whether they are virologically suppressed or not, gave these injections, and they found that very large number of patient population were just suppressed. So they concluded, it's a very important study, especially even in our Indian patient settings. Population with the high rates of adherence issues, because they have had a lot of mental illness, they had housing issues, but when they give this, they have 96% achieved virological suppression by week 26. So thereby, they're meeting their primary endpoint. So overall virological failure rate was 1.5% in this population with and without virological suppression. Baseline was very similar to 1.4% rate in phase 3 trials of people with HIV and virological suppression. Very clearly shows that so robust, these long-acting cabotegravir and rilpivirine, even in people who are not suppressed earlier with any other regimen, just suppressed. But the carry-home message is, so here, the investigators, what they did was, they excluded all those people who had NNRT mutation. So when you extrapolate this data into our own clinical practice, we had used a lot of nevirapine in the past, TLE, tenofovir, lamivudine, efavirenz. Those patients, either they are virologically suppressed or not suppressed, we had switched them to TLD. In those population, we do not know whether they have NNRT mutation, whether this strategy will work or not. At this time, we do not have a good answer. So again, the investigator concluded they call for a randomized clinical trial for such a population. Again, but good carry-home message is it works, particularly in people who do not have NNRT mutation. If we know that they never failed with their TLE regimen, we already moved them to TLD, this will work extremely well. Or even if they have a TLD, and they have been viremic because of their adherence, they never exposed to NNRT, this will work very well. So that's something what we can take it from our study when this cabotegravir rilpivirine will be available in India. So moving to the other long-acting drugs and other strategies. So there is a drug called lenacapavir. I think I had spoken to this group in the past, where this is a drug where at the maturation level, it works at that level, where it can be given as a subcutaneous every 6 months, and also now approved by US FDA. And there are all trials been carried out in the past, where using this drug, both in treatment-naive population as well as in the experienced populations have worked. A study called Calibrate and Capella have shown, this drug works along with other antiretroviral drugs if it's been given every 6 months. But in those trials, they use other antiretroviral drugs which should be given every day as an oral tablet. So this particular presentation, again, going to be very interesting and exciting, especially for clinicians who are taking care of patients for a long time. So this is a drug, what they use, lenacapavir. Along with that, they also use two other broadly neutralizing antibodies. One called terapavimab, another one called cinlerimab. I know it's very hard for someone to pronounce. Even for me, it took some time to, pronounce this word. So this for every 6 months virologically suppressed people with HIV. That means someone who is suppressed, can we give this combination every 6 months? That means they have to come to the clinic twice a year, to get the shots. As many of you know that lenacapavir is a capsid inhibitor at the time of maturation. With a very long half-life, very low potential for drug-drug interactions. The previous studies called Calibrate and Capella have very clearly showed works both in treatment experience as well as in treatment-naive population. So here, in this particular trial, along with lenacapavir, they also added two broadly neutralizing antibodies. One called TAB, which targets the CD4 binding site of GP120. Another one called STAB, which target at the V3 glycan of the HIV-1 envelope. So again, this was being chosen for two different targets in terms of neutralizing, these viruses. And again, the study investigated whether this combination of lenacapavir and these two broadly neutralizing antibodies, TAB and SAB, would maintain the HIV suppression for 6 months, people with HIV suppressed on another ART regimen. So this is a randomized, study, but on a very small number of population, just a 21. It's not a very large trial, so you can call it as maybe a phase 1. on patients who are being virologically suppressed and with a CD4, good CD4 more than 500, they studied two different dosages of one of those broadly neutralizing antibody. But other two drugs are the same, lenacapavir and TAB 30 milligrams per kilogram. And the SAB broadly neutralizing, in one arm, they use 10 milligrams per kilogram body weight, another one 30 milligrams. Again, the study, the results which I'm going to show is 26 weeks data. But again, the study will run up to 52 weeks. And again, with the very clear endpoints of proportion of patients with plasma HIV RNA less than 50 copies and more than 50 copies, and change in CD4, and also the serum concentration of these various molecules and the safety and tolerability. So again, baseline characteristic between these two small arms are being almost similar. There is no major in terms for any type of biases. And very clearly, they found that 90% of them, they continue to have a virological suppression, which is very exciting, right? We talk about everyday oral therapy. We tell our patient, just now I showed you some data on every 2 months of injectable. Now here, just every 6 months. So then they can totally forget, just have these shots a year, and they are being able to maintain this virological suppression. But one thing they have used in this particular study is just before randomization, they also looked into that whether these individuals had any resistance mutations to these neutralizing antibody. That's very important. We have learned now from COVID that we use a lot of these monoclonal antibodies, but now with the new variant, it did not work. Similarly in HIV, a lot of such these BNAbs had been used, and over a period of time did not work because of it had developed mutations. So here again, it's carefully been selected in a way that they did not have mutations where it was able to suppress a virus and maintain that suppression. And when they look into those safety events, which has been safe, adverse events are similar in both those 10 milligrams and 30 milligrams, and no clinically relevant treatment emergent lab abnormalities. Only those injection site reactions have been seen, and nothing major except one case had some cellulitis resolved with antibiotics, but otherwise nobody discontinued this molecule. So the early phase study demonstrates that the virological suppression can be maintained for 26 weeks with a combination of this lenacapavir, which is a capsid inhibitor, and with two other BNAbs broadly neutralizing called TAB and SAB. One acts at the CD4 level, another one at the B3 loop. So they found that 18 of the 20 participants maintained virological suppression after single administration of the regimen. So it has been very safe, except mild injection site reactions. And now there is a phase 2 study has already been developed, and it has been underway, so which is with a very large sample size with lenacapavir, TAB, and SAB as a twice yearly regimen. This is something what we should look for this, especially for our patients who are on long oral antiretroviral therapy, suppressed, they have a pill fatigue, how we can use this type of strategies in those patients of giving yearly twice. Moving to those, another newer drug called Islatravir, which I had spoken to this group in the past from previous conferences, where such an exciting molecule, which is called NRTTI. So this is a translocation inhibitor. It works a little different other than like NRTI, like a tenofovir or abacavir or AZT. It's a translocation inhibitor. And basic science studies also shows it works against resistant population to AZT, 3DC, tenofovir, and abacavir. So that means it can be a potent drug for first line, second line, and third line. This was also initially studied both for treatment as well as prevention, and also it has got a long-acting potential. But unfortunately, a couple of years back, these trials were put on a hold because the investigators found that there is a reduced lymphocyte counts in some of those ongoing clinical trials. Initially, they didn't know the mechanism. Now, some pathway had been identified, why it caused. It's due to the accumulation of this particular molecule of Islatravir triphosphate in lymphocyte, which has led to supratherapeutic levels causing apoptosis. And similar things have happened in the past with the protease inhibitors. Thereby they have reduced the dose and have used ritonavir as a boosting effect. And it is a little different mechanism where they have a supra therapeutic level and causing this apoptosis. As a result, there is a lymphocyte depletion. And because of those, both PrEP trials and as well as many of those treatment trials were put on hold for a couple of years. And now, after assessing all these, now the drug with a different dosage, the trials have restarted. These are the various trials which have happened in the past. The first half is for the prevention and second for treatment, and which are all put on hold for a couple of years because of this lymphocyte depletion. And again, if you see this, those various trials which are put on there, you can see this with a 60 milligram for prevention. So this is a decline in lymphocyte percentage from the baseline. That's huge. And even the treatment from 15% to 2%. So with a different dosages, starting from 0.75 milligrams to 20 milligrams. This very clearly shows that on looking at this, hey, this is something related to some type of dose dependent. Higher the dose, more chance of lymphocyte depletion. So, but also they found in these studies, when they stop those drug in those trials, again, the lymphocytes all return back to normal. So that means it is not a permanent effect, something happening very temporarily because of the accumulation of this molecule causing this. That's something which has been found in some of those prevention studies when they stopped this particular molecule. So, and also there are several studies, they looked into that at the different dosages where they found that anything from 60 milligram, 20 milligram, even up to 0.75 milligram, they continue to have a decline in the CD4. But when it's been stopped, it again, came up. This is something what's been seen, in this particular studies. But what's been seen in this particular study is, again, it's all found, it's all with a dose dependent. So when they reduce the dose to 0.25 milligrams, where the mean percentage of change in the CD4 count was higher in the comparator group receiving the Islatravir, where in the 0.25 milligrams, it is almost the same, but anything more than that, it's, they are seeing, this type of effect. So that means very clearly it is due to some type of a dose dependent. Hence, the group started looking into that, what could be the particular dose should we do that. So they conducted a dose ranging study, then they gone back into that and looked into the lymphocyte population of 0.25 milligram, 0.75 and 2.25. And they found that the effects were comparable in 0.25 milligrams, both in the placebo group, that is where they used tenofovir, lamivudine, and doravirine versus this drug. But in the other groups like 0.7 and 2.25, they found there is a lymphocyte reduction. So this again very clearly shows that it's again the dose dependent. For that, now the group is working on what could be the appropriate dosages, for this particular molecule to do with. So they concluded by stating that the higher doses will not make it to the therapeutics or for prevention because of the lymphocyte depletion. But on the other hand, lower dose will have an effect. And also it's a very exciting molecule because with a very lower dose of 0.5 milligram, you can also use it for as a PrEP, long-acting PrEP. Then again, now fresh studies are needed, whether the lower dose will be helpful to prevent this HIV infection. I think fresh range of studies are being needed, which the group is been now planning on that. So based on all these available data, now there is some modeling exercise had been done, and based on that, they have identified the dose mainly for treatment. 0.25 milligram or anything lower than 0.75 will be a better drug. But on the other hand, for prevention, you need a little more, higher dosage, because when you give this as a long-acting injectable of every month or every 2 months, where you need to have a little higher dosage to stay on. I think that type of studies will happen. Again, this drug is not going to be available for therapeutic use in the next year or next couple of years. But on the other hand, both to know that because it's the only molecule on the nucleotide inhibitor, it's now currently under development at a little different level, at the translocation level, which will work against all our resistant viruses to NRTI. Moving to the DEF study, this is again a second-line study, which is a large global study, which has happened in Asia, in Africa, Latin America. So this is to understand different regimens for second line when patients are failing the first line in NRTI, like a TLE. So it is a randomized trial which compared two different strategies. against a standard of care of 2 NRTIs and a ritonavir boosted PI. So in this particular study, which compared 2 DTG regimens for second line. These are all patients who failed TLE containing regimens or AZT with 3DC nevirapine or efavirenz, which compared against 2 NRTIs and a boosted darunavir. Here again, a darunavir is 800 milligram, ritonavir is 100 milligram, and which is available in India now as a co-formulated tablet. And also, there is another regimen has been used to compare with dolutegravir along with darunavir 800 with boosted ritonavir, which again been compared against 2 NRTIs and boosted darunavir. So this is a typical design of this study, which is a non-inferiority design. People who have been failed with a TLE or any NRTA containing therapy, they were randomized into 3 groups. One group, the standard of care, that is 2 NRTIs and boosted darunavir with 800, 100. And second group received an integrase inhibitor of dolutegravir and a boosted darunavir. And a third group, which is a challenging group, which recycled the NRTA, that's a tenofovir which was used for first line, and along with DTG, which many of us do in our clinic practice, just to see, can we recycle this tenofovir? Again, it's such a big study, 831 participants, a very robust study, very randomized study. And this is a baseline characteristics. If you look into that, it's almost similar across all the arms in terms of sex distribution and CD4, viral loads, and the median BMI. And they look into those snapshot primary outcome where we presented this as a late breaker at the CROI, where if you see these between these 2 bars on the green and orange is the one patients who are on dolutegravir and darunavir, and green is on the standard of care with the 2 NRTIs and the booster darunavir. If you see this, the combination of dolutegravir and darunavir ritonavir, which has been non-inferior, and also we found it's superior, a little superior, which is very surprising, because our earlier second line study, as well as other ACTG 52, 23, all these showed there is no difference between 2 NRTIs and a PI versus an integrase inhibitor and a PI. But here it showed a little superior. And also, if you looked into that, this dolutegravir, darunavir, ritonavir is superior as compared to 2 NRTIs and darunavir. And when we looked into those arm of recycling tenofovir from the first line, and along with that adding lamivudine and dolutegravir, which was non-inferior as compared to the standard of care. So that means the study also showed you can just recycle and add dolutegravir if somebody is on efavirenz on the first line, which was earlier shown in one of the trial called Nadia, which has already been published. Now this study, very well support those, hypotheses. So this is a CD4 change we have seen in this particular trial in the arm of dolutegravir and ritonavir boosted darunavir. There is a 56 cells increase as compared to the standard of care, statistically significant, and also in the TLD arm, where there is a 39 cells mean increase as compared to the standard of care. This is another thing very important, which I'll talk more about in the next part of my talk on weight gain. So we found that both arms which received dolutegravir with the darunavir or dolutegravir with tenofovir, they had a higher weight gain as compared to the arms who did not have a dolutegravir, where they have used tenofovir and a booster, darunavir. This clearly shows that dolutegravir is causing, this, which again, there are several studies have shown that, which I'll talk to you soon on that. Coming to the other safety, there is no major things. And we also have seen 39 pregnancies in this study of 831 across the globe, mostly in Africa. No congenital abnormalities. So that means darunavir 800 is very safe in pregnancy. Dolutegravir has already been safe based on the SEPAMA study. And there are a few adverse events happen. Many of them are, very mild and not been very related to any of those, drug related to discontinues are a very mild, grade 1 or 2, but otherwise been very safe. So we concluded by stating that the regimens of tenofovir, lamivudine, and dolutegravir, which has been recycled from the first line, and also the new regimen of dolutegravir and boosted darunavir 800, which is non-inferior to the standard of care. Also, we showed the combination of dolutegravir and darunavir is also superior to 2 NRTIs and darunavir. So again, this is something very interesting. But again, more work on that, because in a population with hepatitis C, we cannot do this. We need a tenofovir and a lamivudine. This is something what as a clinician can choose this. And all those treatment combinations are well tolerated. We have been continuing this study for over week 96. We'll be reporting these results over a period of time. Moving into the next phase of my talk, before I end my talk presentation, is on these weight gains. We all know that integrase inhibitor, either raltegravir or bictegravir or dolutegravir, all these can cause the weight gain from earlier published studies. The first one of those study from a resource limited setting, which recognized this was called advanced study, where they compared three different arms. One received tenofovir, lamivudine, and efavirenz, which was compared against tenofovir, imtrasodabine, and dolutegravir. Another group, TAF, imtrasodabine, and dolutegravir. This study was done in South Africa and Johannesburg, where they very clearly shows that in women, the arm containing TAF, imtrasodabine, dolutegravir have a very high weight gain of more than 10 kilos, and in men around 5 kilos as compared to efavirenz or tenofovir, dolutegravir. Now, following this, a lot of people started looking into that. And our group in Chennai have earlier shown, and we have earlier shown that it's not only this weight gain was seen, not only in TLD, but also in TLE very minimally. But in TLD, it was huge. But over a period of time, after 12 months, it started normalizing. But again, weight gain is continuing to be seen. But on the other hand, our group and others also have shown there is a new onset of diabetes, incident of diabetes while someone is on dolutegravir-containing regimen, as well as someone who's already been diabetic while they're on diabetic drugs, they are developing hyperglycemia. This also been now started being noticed from sub-Saharan Africa as well as from other Latin American countries. Now let us go to this CROI 2023 from some of those presentations on weight gain. So this is a presentation from Kenya, where in their program, where they have done a large transition from NNRTI to TLD on a 23,000 patients who moved from NNRTI to dolutegravir, and they followed them for 24 months, and they reported this analysis. Out of those, 71% switched from a efavirenz-containing therapy, another 29% from nevirapine-containing regimen. And they found that participants gained on an average of 1.3 kilograms, with a standard deviation up to 5 kilos during the entire study period at an average of 0.5 kilos per year. So it shows that there is a weight gain. The rate of weight increase was significantly higher post-switch as compared to pre-switch. And also the rate of weight increase post-switch was higher for females. They've seen in sub-Saharan Africa, they've seen that in Afro-American women as compared to males. And also for participants switching from efavirenz compared to nevirapine. This is something what's been very interesting. And also there are data showing that efavirenz can cause anorexia, where people don't, they don't have a feel like eating. They have a poor appetite. Not only the CNS disturbance, but also poor appetite. Because of that also, they can have a weight loss. But here, dolutegravir, when you switch them, they've been eating well, they're doing well, and putting on weight. And this was seen as compared to, nevirapine, huge weight gain in patients who are switched from efavirenz to DTG than from nevirapine. So again, more work now being needed with efavirenz, what really causes weight loss. And with DTG, is this while switching or while starting itself? Again, in our practice, we have seen patient who are initiating also has got a weight gain with DTG. So now, when someone is on integrase inhibitor, of course, we have seen this weight gain, from various studies. If you switch them to long-acting injectable of cabotegravir every 2 months, which I showed earlier from the SOLAR trial, and with the rilpivirine, whether the weight gain is continuously going to be there or not, because you are giving this only every 2 months. So SOLAR trial, which I showed, which showed virologically efficacious is to long-acting injectable and as well as with the rilpivirine. That's a study design which I showed earlier. Again, they also did a sub-analysis of looking into the weight changes as well as some of those metabolic parameters. So that's a baseline characteristics. Again, if you look into the BMI, it's the same in both the similar in both the group. There is no difference at baseline. When they looked into those changes happened over a period of time. So both had gained weight. Both people who are on oral therapy as well as people who are on long-acting cabotegravir and rilpivirine. So that means when someone on everyday oral therapy, they're putting on weight. If you're switching to long-acting cabotegravir and rilpivirine, they will also be gaining weight. There is nothing like to show that they will not gain weight at all. So what they found in that is 3% of those long-acting cabotegravir rilpivirine arm had weight increase of more than 10% of their body weight versus 4% in continuing the oral tablet. This very clearly shows that there is no major difference in terms of changing from everyday oral integrase inhibitor. Here they use Victagravir to dolutegravir of long-acting injectable. That's been shown in the sub-analysis of the SOLAR study. Again, when they looked into the BMI, they have seen the similar observation. There is no significant changes between the two different groups. And also, they also did further sub-analysis, looked into those waist circumference and as well as hip circumference, and also various metabolic syndrome, insulin resistance. Although they found there is no difference between the different arms. So that means it is particularly seen in all the class of integrase inhibitors, including these long-acting, cabotegravir. So they concluded the sub-analysis of this SOLAR study on the weight and metabolic changes, stating that so there is no difference between continuing everyday oral therapy in terms of metabolic complications as compared to this long-acting cabotegravir. So as a clinician, you're going to ask me this question in the end, hey, what should I do? You showed all this data. So what can I do when someone having weight gain? So at this time, there are several studies are being planned. There are one study which was presented last year at the drug therapy conference in Glasgow. What they have done is on women patients who are on stable, it's called DORA, the study called DORA, where the women patients who are on stable on tenofovir, lamivudine, and efavirenz. So they moved them to a combination of tenofovir, lamivudine, doravirine. Doravirine again is not a new drug. It's been there for quite some time now, more than 5 years or 6 years, got approved as an NNRTI. I was a second generation NNRTI, where they moved them in 53 patients. And also women who are on stable on TLD, they moved them into tenofovir, 3DC, and doravirine on 47 patients. What they found in that is patients who are moved from efavirenz to doravirine, they found a higher weight gain. So that means something problem with the efavirenz, which is not making someone to put on weight. And when you move either to dolutegravir or even to doravirine, which is a NNRTA, not an integrase inhibitor, they're able to see this weight change. But on the other hand, when someone who's on TLD, already on integrase inhibitor, when they move to doravirine, the weight gain was only very minimal. So that means, again, when you move from NNRTA like efavirenz, the weight gain was huge. And when from integrase to another molecule, still there was a weight gain, but there was been very minimal. So again, the question is, will this doravirine will be a good molecule for comparing that patients? So at that time, we do not have any answer out that. So we have got even Indian companies planning this molecule. So DCJ has given approval to develop by the Indian manufacturers. So you will hear that from there soon. But on the other hand, there is a very large trial currently being planned. This is in South Africa, but they're also been planning a large global trial. These are male patients of two different arms. One arm receiving TAF, emtricitabine, dolutegravir to compare against tenofovir, lamivudine, and doravirine. It's just planned. It may take some time, not only to look into the virological success, but also resistance profile, as well as the body composition, weight gain, BMI, and various metabolic. This will be a very important trial to answer this question. Do we have an alternative to our integrase inhibitor dolutegravir in the form of doravirine? But I think the earlier data called DORA did not support that. But now this purely randomized trial might open up the floodgate of whether we'll have an opportunity. But on the other hand, as a clinician, what you can take home from those earlier presented studies at CROI 2023, especially on weight gain. If we look into the depth study, we also did a sub-analysis. So this depth study happened in Chennai, in our clinic, in Thailand, in Latin America, Sub-Saharan Africa, and Europe, and even in the developed world, on 831 patients who are switching from first line to second line. So when we looked into those weight gain analysis, there was a 2.7 kilo higher weight gain in patients who are on dolutegravir and darunavir, as well as 1.7 kilos on dolutegravir and tenofovir, as compared the arm which did not have a dolutegravir. So that means the arm of darunavir ritonavir might be better in terms for weight gain. So this is something a carry-home message. If we feel that, hey, someone who is on dolutegravir, the weight gain is going to be huge. If at all I wanted to change, right now I don't have doravirine, I will never go back to efavirenz, which will cause resistance and so many other disturbance. Can I to move to a PI? I think based on this depth study, might be this darunavir 800, ritonavir 100 can be an option. I will not say that it will take care of the weight gain because we have not done a follow-up trial on this, but this could be one of those carry-home message. from such trials. But this may not be a good option, especially for people who are initiating treatment, because we don't want to give any protease inhibitor for initiating treatment. We have seen that in the past, and it is not a good drug along with the tuberculosis. No, and also it can also produce several metabolic syndrome because of this ritonavir and all this. So you may have to have a very close follow-up. Just for weight gain, if you change this, you may have to follow a lot of other metabolic parameters so that they won't develop other comorbid conditions. This is something you carry home. I'm not asking you to switch. This is something what you can use it in your practice. Now, moving to another very nice presentation, especially on this weight gain. Hey, now you ask a question. Now this weight gain, my patients are putting on weight. They're complaining me. What will happen to that? Will they, other than cosmetic, whether it will cause any problem? So there is a very nice Swiss cohort study was been presented at this conference. I thought it's a very nice presentation for clinicians, especially when they're using this integrase inhibitor. What they did is they compared patients who are using integrase inhibitors, any integrase inhibitors, they compared with non-integrase inhibitor, especially if there is an incidence of cardiovascular disease, any new occurrence of any cardiovascular disease. We all know that this integrase inhibitor can cause weight gain, as well as earlier one of those response study, which was published last year in Lancet, showed there could be an excess incidence of some cardiovascular even particularly in people who are initiated on Instagram, but they had certain confounding factors because they mixed participants both from naive and experienced population. So this particular study, evaluated on people who initiated on integrase inhibitor, and they compared that with non-integrase inhibitor. So this is a schema of this particular study where patients who are being ART naive on 5,362 HIV-infected patients, where 1,837 received integrase inhibitors, and 3,525 received other ART, which can be a PI or other regimen without any integrase inhibitors. So they looked into the primary endpoint of first cardiovascular disease event, including myocardial infarction, stroke, or any other complication which needed any type of any invasive cardiac procedures. So this is the baseline characteristics between the arm. There is no difference in terms to give any type of confounding factors in terms of BMI or age, or a CD4 cell count, or the history of smoking, or history of baseline cardiovascular disease, or a history of diabetes. There is no difference in terms of at the baseline. So when looking at the follow-up over a period of time, what they found in that is they started with the raltegravir when it was first licensed in Switzerland. Then over a period of time, they were all being moved to dolutegravir. It's been happened. And they compared this with boosted PIs. If you look at this graph on the right side panel, their participants who are on integrase inhibitor or other regimens, which is most of them are on boosted PIs, they found that there's no difference being observed when they adjusted for all the other risk factors for developing cardiovascular event. This very clearly shows that integrase inhibitor, either dolutegravir or raltegravir per se, did not cause any increase in cardiovascular event as compared to protease inhibitor containing regimen. That's something that's very important for clinicians. Yeah, putting on weight, someone on dolutegravir containing regimen, are they going to develop any cardiovascular event quickly or not? So this is something this study shows that there is nothing major been happening. Since we don't have any other alternative at this time, I think this type of data are very important for us to reassure our patients, or to continue these regimens. So this particular group from Swiss, they concluded stating that no difference in terms of rate of cardiovascular event between people who initiated on integrase versus other non-integrase containing regimens. But on the other hand, it's time that whether we need a little more randomized clinical trials, particularly on this very difficult to design such study, because it may take longer time for someone to develop an event. So you may need a very longer follow-up to show whether this particular regimen is good for preventing cardiovascular event. Now, moving away from antiretroviral drugs, I'm going to conclude my presentation by showing some very interesting data on monkeypox in people with HIV. So I know this monkeypox caused a little scare among all of us, but fortunately did not cause a major impact in India. So there were around 85,000 monkeypox cases in 110 countries were being reported in the very recent so-called Flutter pandemic. We heard mostly from the developed world. Out of those 85,000, 38 to 50% were in people living with HIV. So that's been seen mostly in Canada, in the United States, and Europe, and some parts of Africa. And again, most of those happen in patients who are on antiretroviral therapy, The viral load was less than 50 copies and CD4 was more than 500. And their presentations were similar among people with HIV without HIV, especially in people who have got a suppressed viral load. Very limited data has been available, especially in people with advanced disease. There are 2 Nigerian reports showed very severe, 2 CDC report with severe complication, particularly rectal disease. So in this CROI, there is a very nice presentation on the compiling of monkeypox cases in people with HIV with a very low CD4, less than 350, less than 200 and under. This was presented by the Share Network by CROI, the very nice clinician from England, from London, and a very nice researcher. So she had a network of clinics where they have been taking care of people with HIV and monkeypox from 19 different countries, mostly in Europe, Americas, and 1 clinic in Africa. So they studied and reported on 382 patients with HIV and monkeypox. Here, monkeypox was confirmed monkeypox with PCR, who had a less than 350. And they found in that variety of lesions, where just for one of time, I'm not going to the details of the lesions, rectal, oropharyngeal, genitourinary, and some of the lesions were very severe and necrotizing. So they also, this group of investigators, they also stratified by CD4 and viral load. What they found in that is outcome is, in patients, if you see this bar charts on your left side, and this orange color is patients who died. And lighter green is patients who went into ICU with HIV and monkeypox. And this lighter color is on inpatients, and the purple one is on outpatient care. The left side panel is on stratified by CD4. Someone less than 100, 57% chance of dying with monkeypox lesions. And in less than 200, 4.3%. And someone viral load, if you see on the right side, stratified, if it is more than 4 log copies, higher chance of dying as compared to people who got a suppressed viral load. This very clearly shows that immunosuppression adds to the monkeypox disease progression, particularly in HIV. That's been reported by this. Also, the group is stratified by CD4 between 100 and 200, and in terms of presentation in different regions, respiratory, ocular, gastrointestinal, skin, CNS, and things. And they found that persistently, someone CD4 is less than 200 or less than 100, more chance of attacking more different organs and as well as different severe lesions. So that means immunosuppression can be a severe risk factor for a monkeypox disease progression. And when they tabulated and analyzed the deaths happened, no one died when the CD4 were more than 200. It's very interesting. Just suppressed viral load, good CD4, monkeypox solution did not do anything. But when the CD4 is less than 200, 15% died, and less than 100, 27% died. And it's all happened such a sudden of 2 to 3 months, before we started working on this. But this group very interestingly collected all these lesions. Some of them are very severe coalescing necrotizing skin lesions. And they also developed severe respiratory symptoms, rectal complication, oropharyngeal, ocular, CNS, and all those they have seen. And also the group observed there are no deaths that happen in people who are vaccinated with monkeypox. There's a small percentage of the people who had received vaccination, because this vaccine is not widely available. It was available either in Canada or in some parts in UK, but not everywhere. Where they received, they never died. So I think this vaccination definitely protected, similar like we have seen in COVID. So again, as clinicians now, we didn't see this monkeypox as a big thing in India. So I think we should look for it. And people with severe HIV disease can cause a havoc in them. And there are various treatments being provided for monkeypox. One such drug which was studied and tried was called Remark, which has got a limited response in these patient population, but they also found some resistance to this particular drug also been seen. Now other clinical trials are currently been ongoing, particularly combination of different antivirals for monkeypox. In conclusion to monkeypox, all those deaths, what they've seen in people with HIV was in less than 200 CD4. And mortality was higher when the CD4 is less than 100 as compared to less than 200. And severe necrotizing disseminated form of monkeypox has been described. Severe complication deaths correlate to CD4 and viral load. And also, interestingly, they also have noticed monkeypox iris, particularly people who initiated ART when they had monkeypox or they did HIV test on positive. They had a higher chance of monkeypox iris, where the lesions are so severe, causing even death. I'd like to conclude my presentation stating that this particular CROI 2023 happened in Seattle, where very interesting, this long-acting antiretrovirals have some usage in our patient population, and many of them in pipeline. and we need to look for it. And also this very nice, interesting presentation of combination of this long-acting antiretroviral, the lenacapavir, with broadly neutralizing antibodies once in 6 months. Now the phase 2 study is underway. It's going to be very promising, going to be very exciting, both for clinicians as well as for our patient population. Just 2 shots in a year, suppressor virus maintains. Islatravir, which showed promising, put on a hold, but now might come back because now it's found as dose dependent. Is again a new molecule under development. Our second line study of depth study, where again a new evidence of dolutegravir darunavir is superior, and also the data on the weight gain which I showed. Integrase inhibitor and variant issues will continue. We need more and more study to solve it, to help our clinician, help our patient. What could be the possible solution to that? Monkeypox in HIV, when the CD4 less than 200, can be severe and can be a killer disease. And this conference, there are a lot of other interesting presentation, new finding also, especially on newer TB regimens, a study called Truncate TB. There are presentations on hepatitis B, clearly showing that it's incurable, you need lifelong treatment. Newer COVID oral antivirals for early disease, STI prevention using doxycycline, and long-acting PrEP, all were being discussed. Just for want of time, I will not be able to go into those. Those details will be covered next week at our 8th Society of India conference called ACCON 2023, which I'm sure many of you have been attending. If you are not attending, register for this, happening in Delhi on March 17 to 19. We have very interesting international national faculty to discuss about some of those new findings which have recently been presented at CROI, and some of them which I didn't cover in this. Again, thank you for this opportunity. I'm happy to take questions in the remainder of the time. Thank you again for the organizers for this huge opportunity. Thanks.
So thank you very much, sir. It was indeed a great pleasure to listen for last 40-45 minutes about what are the new developments which are happening at CROI. And I'm sure there would be a lot of questions. So I request all the panelists to just put their questions in a chat box. And if required, my colleague will also unmute you, and maybe you can ask the questions directly. And till the question comes, sir, I have sorted out some of the questions. I would like to know your views. And you have very rightly mentioned that long-acting antiretrovirals are going to be there. And you have presented a very nice study of a solar study of captegravir and rilpivirine. So I just want to ask you, sir, this combination, what is about the mutation? So what is the chances or in the patients who have already shown or they have a mutation? So how it works, sir, in that subgroup?
If I understood your question correctly, mutations to what? Which drug?
Maybe you said the baseline drug, and you said reusage of also, or maybe the very nicely your used a word. I am not getting that. Maybe recycling, if I correct, recycling.
If I understood your question correctly, is it you're talking about for the depth study or for the solar
depth study? Sir, depth study.
Depth study. Okay. So in the depth study, what we did was patients who are on NNRT containing therapy, either they were on TLE or in some other sites they are on ACT3DC nevirapine or ACT3DC efavirenz. If they have a virological failure, they are randomized into 3 different groups. One group were randomized to standard of care, where they received tenofovir, lamivudine, and booster darunavir. Another group received dolutegravir and booster darunavir. Another one group recycled the same drug. Even whatever they have tenofovir, they did the same thing. In the first group, the standard of care, if you know that the earlier guidelines, somebody who's on tenofovir, you move to AZT. Somebody who's on AZT, move to tenofovir. Here in the third arm, we did as an experimental arm of recycling the same tenofovir to tenofovir for second line along with the dolutegravir. And we found that which has been non-inferior. I think similar observations were also been seen by the Nadia study group earlier, and which has already been presented. So I think this depth study very clearly supported that this form of recycling, works.
And there's a question, sir. I am not very sure what is the name of the doctor. So what is the regulatory status of this long-acting injectable? So in US, Europe,
Yeah, it's already been approved for use, both for treatment as well as for prevention in the US and some of the select countries in Europe, in England and in Canada. We do not have this yet in India. I think you have to tell the answer. Probably you might be the one you might be developing. Maybe you can give us what's happening. And this particular molecule, as I said earlier, has got an NNRTI, rilpivirine. We have used a lot of NNRTI in our patient population, like nevirapine and TLE failures. How this will work, I think we may also need a study for that population. But on the other hand, people who do not have an NNRTI mutation, who are already freshly started with TLD, they have adherence issue, this can be a wonderful drug, which I showed in that particular data presented from San Francisco.
And whether this long-acting injectable has to be taken under supervision?
Right now, it is like it is not like a subcutaneous or it's not like a insulin. So it should be done in a healthcare setting as a deep intramuscular injection, and there's an observation period. So it should be done under a medical supervision. Either you have to come to your own clinic or some nurse can go home and do. It should be done by a healthcare worker, either a nurse or by a doctor, somebody gives that.
So then, sir, how you look forward the future of this drug in a resource limited settings where the patients?
I think that will be an answer. That will be a question we need to study. We have seen now this COVID vaccination, right? Where millions and millions of people, billion people been vaccinated by our national government. That's possible, right? So many other things. We did a lot of toss shifting, toss sharing, did that. But it's not like a COVID vaccine. They also did under the tree, roadside and everything. But here we can't do that. So I think we need to develop some type of a strategy, how we can have a safer place for them so that they are not ostracized, and also how to dispose all those needles. And again, it has to be given on the buttocks, so it cannot be done on the street or under open space. You need a private place to be done. I think these are the next step we need to work on. And also, there are groups now working on whether it can be given as a subcutaneous. Right now, the current preparation is intramuscular. There's a group working on as a subcutaneous. There are also groups now working on some type of a pump where you use that to do that. I think there are a lot of strategies coming up. I'm sure there will be a way how we can administer on large number of population.
We are also very much encouraged with the experience of your center, which was a part of a global clinical trial, and that was really, really encouraging. So you do mention quite a bit about the weight gain with the integrase inhibitors and the SEGA around that. And we also seen that new onset of diabetes and hyperglycemia, but weight gain was more in females, but same, what is about the hyperglycemia and new onset of diabetes, which was also gender specific or something like that?
It's been now noticed. There are several groups are noticed. There are also now presentations coming from Nigeria on this. I think it is too prematurely to show that hey, you need to change something with the dolutegravir, which has been absurd. Not only, I'm sure most of the clinicians who are on this webinar now, if you ask them, they keep seeing this. Whether we need to alter some of our diabetic medications or not, or we need to do a lot of other lifestyle modification along with the dolutegravir and along with other oral hypoglycemic drugs to do that. This is something what we need to study, and there is a work in progress. Again, too early to comment what's a possible solution. And right now, we don't have any other alternative to this integrase inhibitor in India as well as in other resource-limited setting because of the robust activity. I think it's time that how we can follow this patient population in a way that providing lifestyle advices in a way that say they won't develop non-communicable diseases. That's something what our HIV and infectious disease clinicians now need to do on our patients.
But sir, the results of Swiss study are very encouraging. Large study, more than 5,000 with a follow-up of 5 years, but which did not show that there is increased chances of cardiovascular what you called as outcome particularly. That was very, very encouraging. And one important question, sir, before we go to the audience question. So Doravirin is going to be available soon, sir. So how you see the Doravirin and its place in therapy, sir, currently?
I think Doravirin is an NNRTI, which has been approved for use in some countries already. It's not a new molecule again. I think 5 to 7 years back, it's got approved, which is a second generation NNRTI. Some of those basic science studies shows it can work against nevirapine resistance as well as efavirenz resistance, but need to be studied in large scale. We don't have good data on the interactions between TB medication, particularly rifampicin and Doravirin. And its usage very widely in resource limited setting. But on the other hand, data is robust in terms of virological suppression. It's been non-inferior to integrase inhibitors, non-inferior to many protease inhibitors, either for first-line drug as well as for people who have been failed, which has already been studied. But mostly it's been studied in initiating treatment. Now, the question on this could be a salvage drug for people with dolutegravir on weight gain. So I think that's a question need to be answered. The data which was presented last year at the Glasgow meeting, the DORA study, did not, give any evidence to us you can change to Doravirin, because they found similarly weight gain from TLE to Doravirin, and also still weight gain was there from TLD to Doravirin. And also, when they did this registration trial called Drive Ahead and those initial trials, also they have seen a smaller weight gain. They have seen that, but not like how we reported with the integrase inhibitors. So I think this is time that could be a molecule. I think the trial which I showed a design, which they are planning in South Africa, and we are also planning that in other countries, including Chennai as well as Thailand and some of the Latin American countries, so that it will be a purely global trial. That may answer a question. So we want to do that very quickly to get that move forward so that will be an answer. But on the other hand, this Doravirin can also be an answer for a lot of other questions, not just on weight gain alone. Now we need other drugs for someone who is failing either dolutegravir or failing other regimens. I think this could be a good drug. I think adding to them, along with our other antiretroviral therapeutics, will be a big boon for our patient population to our clinicians. Since we have already killed some of the drugs like AZT out, D40 is gone, DDA is gone, and lopinavir is gone, atazanavir is in the process of going out. So I think all these together, now it's ending up with only tenofovir, TAF, dolutegravir, bictegravir, and darunavir. I think now bringing a new molecule where we'll have a little more flexibility to move around in taking care of these patients.
So there's a question, sir, like SOLAR study, is there a DTG based study versus long-acting injections?
I think they were all been done in the past at the time of registration of this molecule, where they have continuously found that similar virological suppression, and also they have seen the same weight gain what they've seen the everyday oral tablet versus long-acting injectable. So I think the long-acting injectable here could be a rescue, not just for weight gain, but for reason that people who don't want to take this tablet every day and who can't take the tablet every day, where we feel that they are having blips and not virological failure and blips, this could be a good option to salvage them.
So we discussed about monkeypox, and there's a question whether the cidofovir has any place in the treatment of monkeypox.
Yeah, that's an alternate in treatment. So tetravirapid is a preferred therapy. So there are trials which was planned. Now they have been also planning a combination trial with tetravirapid with cidofovir. So again, cidofovir earlier it was used for CME retinitis with a limited usage, but now these trials are ongoing. I can't use the word this is a preferred therapy, which could be an alternate or add-on therapy.
Okay. Right. So there's a question by Dr. Neto. He says that, sir, anything to change the existing first line for initiation of treatment, which is better than bictegravir?
I think the current preferred therapy, either in the United States and Europe or in India, is a 2 NRTIs and an integrase inhibitor. So again, the preferred NRTIs, either tenofovir or TAF, along with the lamivudine or emtricitabine with dolutegravir or bictegravir, whatever been available, in your clinic. In the United States, so they have the TAF emtricitabine bictegravir available as a single pill, and which is being used as a lot. And when they're using dolutegravir, it is a two different pills. In India, now we have these tenofovir, lamivudine, and dolutegravir as a single pill, TAF, emtricitabine, and dolutegravir as a single pill. And again, in globally, where 90% of the patients who are receiving antiretroviral treatment, they are on TLD combination, that is tenofovir, lamivudine, and dolutegravir. I think to your question, do we need to have another regimen other than this? I think now with the various studies and both observational data and randomized trial, and now it has been recommended that this is a preferred therapy because it's got a robot viral suppression, a high genetic barrier drug, and also it will have a huge prevention effect. If you suppress the virus very early and it is undetectable, U is equal to U, you have a transmission probability and it doesn't fail very quickly. But on the other hand, our weight gain, other metabolic need to be studied in a separate sector. And because of that, at this time, we don't want to move away from the drug till we find another best drug, which is equal in terms of virological success.
So there's a question by Dr. Ravi Bhushan. He's saying, what do you mean by post and pre-switch?
I think when they looked at the weight gain, where at baseline, they started on oral therapy and they had seen a weight gain before switching, that is at 6 months of treatment, and versus they switched to this particular regimen, then they followed up the 6 weeks. So that's what's been shown in this clinical trial, pre and post. So I cannot go back to the slide now. Again, it may take time. So that's something in the clinical trial where we have shown the pre-switch and post-switch.
There's a question by Dr. Pungulali. What are the challenges in implementation of long-acting ARTs in India? I think it's a very long discussion, so we'll.
I think there will be challenges. We'll have challenges, but then I think we all know how we can solve that. Yeah. I think we need to work on how to give this injectable and how to convince the patients to do that, and how to develop the private areas to give this injectable. And the cost concern, today the long-acting injectable is huge. So I did not know the cost in India. What will be the cost in India? But right now, the cost in the United States and in UK and Europe is very expensive as compared to our TLD oral tablet here. So if it is going to be launched in India, is it going to be equivalent cost in India as compared to the oral tablet, or it's going to be tenfold higher? I think these are some of those challenges will be there. I think there are ways where it will be worked out.
So there's a very interesting question by Dr. Twishi Srimali. So what is that? What is therapeutic drug monitoring? So we have thought of we have mentioned long-acting antiretrovirals. So do that require a therapeutic drug monitoring? And if it is, how will we doing?
So when we do clinical trials during the development studies, either the phase 1, phase 2, and phase 3 combination drugs, at that time, we do all these therapeutic drug monitoring to find out how is this drug levels. First, initially in the phase 1 studies, when you do the dose ranging studies to find out what could be the optimal concentration needed to suppress this virus or to prevent toxicity. And similarly, when we combine with other drugs in phase 2 and phase 3 about the drug-drug interactions, we do this therapeutic monitoring. Once that has been set, and we recommend this can be given. So it is not needed as part of your routine practice to do the drug monitoring unless you suspect that there is some particular toxicity in particular individual to do this. Again, therapeutic drug monitoring are not routinely done in the common laboratories. It is done mostly in the research laboratory. You need a lot of expertise to do this standardization. But there are some, these therapeutic drug monitoring has been available when commercially, particularly for tenofovir. It's been, you can do this in the urine as well as from the hair. So the group in San Francisco, they have standardized this. They're also in the process of commercializing, developing a kit by doing a dipstick in the urine as well as from the hair. So this is something what they can find out quickly whether they're adhering to the drug or not. So right now, we are not routinely recommending. Best thing is counsel the patients, improve the adherence and do the viral load. I think that will really help whether they are adhering to these medications.
Sir, let us take last two questions, sir. So Dr. Parth Sarthi, he's complimenting you, sir, for a nice presentation. At the same time, he's asking, is there any relationship between dolutegravir and lipodystrophy? And in his experience, he has seen some patients developing lipodystrophy and abnormal fat distribution while on DTG, and he would look forward for your views, sir.
Yeah, first, thank you for the compliment, Dr. Pathsarathi. So here, coming to these lipodystrophy, which has been widely reported in HIV. HIV itself produces lipodystrophy and metabolic complications. It's been described in the past, even without antiretroviral therapy. When antiretroviral therapy was introduced, when as a preferred therapy as protease inhibitors with the sacinavir, ritonavir, indinavir, we have seen a lot of lipodystrophy, all been seen. And when NRTI, stavudine, and AZT were introduced, we were seeing lipodystrophy in the form of lipoatrophy. All those been seen. So it's been seen, it's been there. So with all those various regimens we have seen. Now with the tenofovir, we did not see that type of lipodystrophy. And also with the efavirenz, we did not see, except there are a small percentage of patients developing gynecomastia. So now in dolutegravir, there are various metabolic events are now recognized and noticed. One is this weight gain, and also this hyperglycemia and the new onset of diabetes. But again, as you all know, as a practicing clinician, when the diabetic patient without HIV, without antiretroviral therapy, can also have a lipodystrophy. If you go to any diabetic clinic, you can see those body shape changes there. If you go to many of those diabetic clinicians, for them, this lipodystrophy is not a big thing. They continuously seeing this. It's a metabolic event. There is something happening. So I think if you have a lipodystrophy in HIV using dolutegravir, who had never used any NRTIs in the past, like AZT, D40, or any protease inhibitors, also look for other metabolic complication. I think that's something can be a carry-home message. So not just on dolutegravir alone, it's a combination of other factors.
I think it's a
question.
Second question also, so we need not to go to the second question. So I think we have, I think the questions are pouring, but maybe we can take a last. Insomnia is a Dr. Ananda Rao. He's our regular doctor who participate in our monthly meeting. So insomnia is a troublesome. DTG adverse drug reaction, but not much spoken about it. Is it so, sir? Insomnia is noted with DTG.
So insomnia, it's a very vague thing, particularly in HIV. With efavirenz, we have seen a lot of CNS disturbances. People who are not able to sleep, they have dizziness, they have a suicidal tendency, weird dreams, and so many other things. But in dolutegravir, some of the earlier studies, they have recognized some sort of a neuropsychiatric, some type of an event, so including insomnia. But that's not seen in very large numbers, particularly from a programmatic perspective. Might be in a small number of patients, but those patients, you need to study what's the cause of insomnia. HIV itself can be a cause of insomnia, where people are depressed, where they have a insecurity in their life. I think these patients need to be studied and counseled for that particular reason. So I won't say that DTG alone. DTG can cause. There are initial trials have shown, but not in large numbers as we have seen in efavirenz.
I think we have covered almost all the questions. So it was really interesting to listen to you and have your expert commentary, because just discussing study is one thing, and you adding your expert commentary is very interesting, and which really adds value to everything. So I have with me Mr. UD Balaji. He is our executive vice president for HIV business India and worldwide. So I invite Mr. UD Balaji for giving the conclusory remarks, and then we can officially close this program. Over to you, sir.
Thank you, Doctor, and thank you, Dr. Kumar. It was very interesting. In fact, in the last 1 hour, you have transported all of us to Seattle to witness the highlights of CROI. Even if we had physically traveled to that place, it would be very difficult to really go through all these sessions and take the best of these things. And you have been able to compact all these things into this 1 hour program. Well, it's always been our endeavor to look at newer options to provide better patient care and to sort of salvage what are the new things that is happening to understand that is happening in the HIV space. So that way, the CROI conference is quite important, and we have made it a point that every year we bring this program, and you have been very kind to host this for us, and we will continue with this. And your insights into the clinical aspects, as Dr. Onkar had said, and the relevance to the Indian environment is very interesting. That's what we really look forward to, rather than even actually attending the CROI conference. So this is we thank you once again on behalf of both the MCure and my team, as well as all the participants who have joined this webinar. Thank you very much, sir, and have a good evening. And thank you once again for your time and efforts in putting this, making this possible. Good day, sir.
Thanks, everyone. And thanks all the attendees, for your patient listening, and look forward to continue to chat with you all. Please attend ACCON 2023 next week.
Sure.
Thank you. So we are closing this program. So Vivek, can you just stop live streaming?